Thank you, Ed, and thank you to everyone at the Milken Institute. I'm Dan Diamond of Politico. I'm pleased to be back. I am joined by four physicians, Dr. Megan Ranney of AFFIRM Research and Brown University, Dr. Babak Sarani, GW, where he leads trauma work at the Center for Trauma Care, Lena Wen, who is a visiting professor at GW's Milken School, but also the former head of Planned Parenthood and the former commissioner of Baltimore City's Health Department, and Dr. Mallory Williams, who leads trauma care at Howard University Hospital. The panelists are many and time is tight, so we're aiming for conversations, not speeches. That goes for Q&A too, and I throw it to the crowd in about 30 minutes or so. But why don't we start with this? It's a time of great enthusiasm for fighting gun violence. We've seen Democrats push funding for the CDC, high school students organizing marches across the country. I was in New Zealand last year when the "This Is Our Lane" hashtag took over social media and physicians fought back against the NRA. I can tell you, Megan, people 9,000 miles away were talking and writing about this.
That's awesome.
It had taken the world by storm. But by the same token, as Ed's slides show, we're still dealing with an epidemic of gun violence. Suicide by gun continues to go up. These issues are not going away. So my opening question to the panel, are we in a moment of optimism or pessimism about gun violence as a public health issue? Megan, let's start with you.
So I would say that we are in a moment of tremendous optimism. I have been working on this issue for over a decade. And when I first started doing work on gun violence, I could not get any medical organization to talk about it. I could not get any large philanthropy to talk about it, right? We now have almost every major medical organization in the country saying that this is a public health crisis. We have all the Democratic political candidates saying that this is a public health epidemic. We have the creation of new groups such as AFFIRM Research, new funding from the Arnold Foundation, from Kaiser. There's a movement growing to treat this as a problem that it can be addressed using traditional health techniques, kind of moving beyond the political impasse. So I have tremendous optimism.
She's optimistic. Babak?
I certainly echo what Megan said. I think we feel the need to provide evidence behind this public health issue, and that really translates into my being able to call fellow colleagues and say, can we do something collaboratively? At George Washington, we see several hundred gunshots per year, but that's not enough to make a meaningful response to a public health crisis. Nowadays, I can literally pick up the phone to a peer, whether it's in emergency medicine or in surgery, throughout the country and say, well, look, a mass shooting just occurred in Florida. You're the medical director of that hospital. Would it be possible for us to work together and see what happened to these people? And if we put all of these events together, we actually form the basis of understanding what is actually happening. So I am extremely optimistic.
Lena?
I don't know if I'm extremely optimistic, but I am optimistic.
Okay.
The language around gun violence, I think, is the most significant thing that has changed, to Megan's point. When I first started as the health commissioner in Baltimore, this is back in 2014, 2015, it was a challenge to explain to people this exact title of our session, that gun violence is a public health crisis, that it is a disease that can be prevented and treated. And it was something that people hadn't heard of before, and when they realized it and saw the data, there was a moment where they said, oh, that makes sense. But people understand that. And I think the link between violence and trauma and how we do have to get to the root causes and go upstream, I think is coming into the public consciousness too.
Mallory?
Oh, optimistic. I think two things. You got physicians coming out of their caves and speaking out publicly about things. That's very optimistic. And two, you have the children from Parkland showing the activism and the civic engagement that the future will bring in our democracy to force this issue and many other issues. They alone give me great optimism.
So as a journalist, you never want to ask a question where literally everyone gives the same answer.
Sorry.
But that's how you feel, and that's important. I will be more pessimistic and say, I have seen this moment emerge where public health language is being applied to gun violence with the hope of winning new funding, with the hope of making progress, and yet Congress has not passed any sweeping gun violence reform. We saw the statistics on mass shootings continuing. Who Who has been the most difficult constituency to convince Megan to win over to this argument that this is a public health crisis we need to solve?
It's a really interesting question. I think, to Lena's point, that the just getting the language out there has been challenging. I think that the idea of this being a public health problem is something that's not necessarily intuitive for a lot of folks. They go, well, why is this an epidemic? How is it that public health will change it? And then moving the discussion beyond policy. I think that on both sides of the debate, there are folks on both sides that think that either we will solve this entirely with laws or that we don't need laws at all. And so creating a middle ground where we can say we could have every law in the universe and it actually still wouldn't solve this, that we need a comprehensive, truly a comprehensive public health approach that involves data, interventions, enforcement. It involves training of police officers. It involves training of community members, and it actually involves leadership of gun owners as well. That creating that conversation where we're not exclusively focused on policy, I think has been the biggest challenge.
Babak, Mallory, you work at major hospitals here in DC. Do you feel like you have the data that you need to understand the gun violence problem?
No.
Continue.
Well, let's go backwards and then forward. We clearly, getting to your previous question, we clearly have some work to do with part of our society who feels that the answers to the questions that we seek end up depriving them of some basic constitutional rights.
Can we be more specific? Which part of our society?
So I would not say gun owners in total, because I am a gun owner and I am a Second Amendment person. And here I am telling you on a stage in Washington, D.C., that we need gun control in America. So that's enough to be optimistic right there, right? But there is a small, narrow slither that I don't think have been effectively communicated with enough regarding the issues that we're trying to really remediate or solve. And all that slither of population can see is this means me not having the constitutional right to own a gun and government control in my life. That's a fact. And we need to accept that fact, and we need to be able to productively craft the language and the agendas to bring them to the table in a very intentional manner and have very open conversations about what the end of the road looks like. People fear the end of the road when we talk about gun violence. And if we don't start talking about how the end of the road looks in a way that they come to the table, feel comfortable at the table, that's going to continue to be a challenge.
Babak?
So a couple of points. I agree by and large with what Mallory just mentioned. To answer your question, do we have enough information to treat the patients today? To treat the patients today, yeah, of course we do. But let's step back from the individual and patient and let's look at the system. The United States of America has never, in its entire history as a nation, ever passed a sweeping law that changed everything at the federal level. Let's talk about today's issues. Helmet laws for motorcyclists, not federal. Seatbelt laws for car drivers, not federal. Drunk driving laws, blood alcohol levels, not federal. Each of those vary state by state. So if we're going to wait for the Congress to pass some national legislation, we've never done that, even for things like seatbelts. So never mind Second Amendment rights. So that's not going to happen. I think we need to work more at the local, whether that's a state or even more local than that level. And at that level, no, we do not have the data that we need. And I think that there are special interests, frankly, on both sides that are completely intransigent and are wholly unreasonable. And if we were to lean on either of those parties on either side of the spectrum, nothing will change either. So what we've tried to do is impart unbiased, right down the middle data with no emotion involved whatsoever to simply say, when a mass casualty event occurs, when one of these public mass shootings occurs, why did it occur? And when people died, why did they die? How many of those people, now the shooting has actually occurred, could have been saved if our response paradigm was different? So we approach it from different angles. One is preventing the event in the first place, and the second one is, no matter what you do, some events will occur. Nothing is going to be 100%. So when that event does occur, how should our response paradigm change to mitigate the risk of death in that event?
Lena, you led Baltimore City at a time when the eyes of the nation were focused on the city after the Freddie Gray death, and you steered the Safe Streets initiative, trying to make the streets safer and cut down on gun violence. When you were working on that, who were the best allies in trying to make that change? Who are the biggest opponents?
It's a great question, and piggyback on Babak's point, I really agree that the interventions have to be local. Because if we wait for national policy to change, it's going to take a really long time. And I strongly believe that if there are things that we can do today, we shouldn't wait for perfect to be the enemy of the good. That maybe we do need all these federal reforms and policies, but if there are local interventions that are effective. So in Baltimore, we used a model similar to the Cure Violence model that was started in Chicago, that's been implemented in dozens of cities around the country and now around the world. We had a program called Safe Streets, still have a program called Safe Streets that's actually expanded. And the concept of this program is that we hire violence interrupters, people who are from the communities that they serve, often people who were recently released from incarceration, and are seen as leaders in the community who have walked in the shoes of the people that they're working with, who are truly credible messengers. And they interrupt violence before it occurs. And in 1 year, I believe this was 2017, they interrupted 800 conflicts, 80% of which were deemed later to be likely or very likely to result in gun violence. Now, that program had broad community support because I think people in the communities themselves understood. I mean, we're not talking about mass shootings in Baltimore, right? We're talking about daily violence and escalation of violence. And people understand how breaking that cycle of violence and trauma, because as we say, it's hurt people who hurt people, that we have to address these root causes too. So I think we had a lot of supporters. The problem was that for any public health program like Safe Streets, there was always the question of how do you make the point of funding something where the end result is what happens when something doesn't happen. I mean, that's the paradigm or the paradox of public health, that it's successful when the thing that you're successful in preventing doesn't occur. So how do you put the face on that? There's the face of someone who was shot. Well, what's the face of someone who could have gotten shot except the violence interruption happened? And so this program, regardless of how successful that it was proven to be and how much it saved in terms of cost of hospitalizations, economic impact, and criminal justice system, every year it was on the chopping block because public health programs are just really hard to fund. And I think that's another part of this issue that we have to discuss, not just the national policy, but the local funding.
And just to push on that, so you're saying that the local legislators, the state health department, who was making the call on the funding that you had to win over and convince this is a worthy investment?
Everyone. I mean, this is a program that, if we had the funding, could have been expanded beyond our 4 sites at the time to 20 sites across our city. Initially, it was started based on federal funding that then the grant ran out. And even though it was proving to be successful, we needed for the city council, for the mayor's office, for the governor's office, for the state legislature, for everyone to chip in. And we were not able to. We eventually got a lot of private foundations, and our federal legislators got additional grants from DOJ and others to help us. But we shouldn't be fighting for funds like that to do something piecemeal when there are actually solutions that can get exactly to what we're trying to do.
Let me push back just a little bit on an isolated local response, which I don't think, by the way, any of the panelists are advocating. I do think local responses are a gigantic step forward in where we need to go. But when you look at the fact that 80% of weapons attached to crimes in New York and Maryland come from and are trafficked states adjacent to them with weaker gun laws, that's where you realize that even if the local municipalities do all that they can, such as DC, we have pretty tight gun laws in this district, you still need some overarching federal response to deal with that aspect of it. Most of our guns here in DC connected to crimes are, of course, coming from Virginia. And so we have to have the federal response.
So I'm going to kind of go off of that a little, though. I think that actually the local response is critical in terms of that public health approach. Our work with AFFIRM Research is national. My co-founder is based out of Vermont. Vermont is awfully different from Rhode Island, and that's awfully different from DC.
Yeah, absolutely.
Another one of our leaders is based out of Colorado. In Vermont and in Colorado, the primary issue is gun suicide, right? And actually nationally, as Dan already mentioned, 2/3 of gun deaths are suicide. Right? And the way that you approach that is very dependent on local resources, mental health resources, what's your culture, why do people own guns, what are the laws around safe storage, et cetera. And so I think that Yes, there are some aspects of this that may be national, certainly data systems, and when you talk about the role that the CDC could have, imagine that we could do for the gun violence epidemic what's currently being done for the opioid epidemic, where the CDC is taking an absolutely national role. But even within the opioid epidemic, which is a similar national issue, you see opioid trafficking, we still have had the greatest success in developing kind of locally appropriate programs, whether it's, and we could talk about kind of both hospital and community-based programs. So I think there is a combination, and from the data perspective, having improved federal involvement would be critical, but a lot of these interventions that are needed to really start to move the needle need to be based in kind of a local culture.
Can I add to that? So 100% on board with what everyone's saying, but in regards to Megan's most recent point, we have tried now we're in our second year, we'll be in our third year soon, looking at people who survive mass shooting events. So we did a bunch of studies on people who died mass shooting events. That's not terribly difficult, believe it or not, because once you're dead, you don't have the laws change in regards to your health record. But when you're alive, of course, you have the right to confidentiality of your health record. So the way things stand as it is there's no way, none whatsoever, for me to track where any patient went following a public mass shooting. So I literally start my research by looking at CNN.com, NBC.com, I go to the local WJLA.com, I look through lay press as a way to generate what happened. There is no actual verified or validated database vis-a-vis what Milken mentioned in the Centers for Disease Control to even start the process of research. That's completely not going to happen. And so one thing the federal government can do, rather than try to pass a sweeping law that probably will never actually happen, is just give us the means to study the events once they do occur, and then allow each of us in turn to take that weight of actually doing it, whether it is procuring funding for doing it, whether it is doing it for free, which is what we do. We don't have a dime I don't have a nickel in terms of my research support. I literally do it on my own time on weekends and holidays.
Yep.
And nighttime.
If only there were some funders at this conference.
Happy to chat, for sure. Yeah.
But Bach, just staying with you for a second and talking about national efforts and your own research, Democratic candidates overall have proposed banning assault rifles as a way to cut down on mass shootings. Are they wrong?
Yes, they're completely wrong.
Yep.
Agreed.
I think it is a straw man. I think that it is easy to get behind because emotionally you say, oh my gosh, if there were only not assault rifles, these kids would have lived. But there are so many preceding steps that lead to that point, right? And by focusing on assault rifles, you are losing track of the things that actually have evidence behind them that could make a difference. Things like improved restrictions around domestic violence, right? So we know that many of these mass shootings, Ed's point story at the beginning, right? It was a domestic violence related shooting that happened in his workplace. And we're finding that so many of these are domestic violence related. Things like counseling people who are suicidal, right? On lethal means restriction in the very short term. It's not about confiscation. It's about temporarily keeping that gun away until that moment of impulsivity and danger passes, right? There are so many things that we can do that have immediate evidence. And there are so many ways that we can grow the evidence base to actually make a real difference. By focusing on assault weapons, we are shutting down the discussion and stopping real change and hope, I think.
And just to clarify the point, so if it's not just assault weapons, handguns are where we should be thinking about.
I think handguns, but it's also all the stuff that happens before, right? It's all the things. So yes, handguns are responsible for the vast majority of suicides and homicides in this country. Assault weapons are a very small portion, just like mass shootings are only 1% of the deaths nationally, less than 1, depending on the year and how you count them.
So quick question, Mallory, you're a gun owner.
Yes.
Do you own a handgun, an assault rifle?
I do.
Which one?
And I think both. I think that, in full disclosure, guys, I'm a colonel in the United States Army. So it's not too much of a leap to know what you have to use when you have to go to other places to use it. Let me say this. I think high-capacity clips may have engendered a different response from the panel versus assault weapons when you talk about the legislative side of things. Because I think
is that fair? High-capacity clips?
Yeah, I agree.
Any clip that has a capacity over 10 rounds.
Right.
So because what I think legislators are persuaded by is that police response times simply cannot be effective if the rounds per minute are exceeding the types of data that we know that the weapons can do now. And so I don't want to get people confused between an assault weapon and high capacity clips, because you could take a high capacity clip, put it in a handgun, and still have the same problem. And so I think that may be a different issue. And in fact, that was the legislation that was marked up out of the Justice Committee at Howard in the House and sent to the Senate.
So I agree with that entirely. And in fact, when we looked at most recently the deaths following public mass shootings, we were able to very clearly demonstrate that the odds, the number of people killed in a mass shooting event goes up if a handgun was used in lieu of an assault weapon. And we included the Vegas shooting, which was all assault weapon, high numbers of people. And the reason is the person who shows up with a handgun, as Mallory just mentioned, can have a high capacity clip on that, so he's got a significant amount of ammunition. Nobody these days shows up with a revolver. That went away with Frisco and the Kid. Everyone has now a semi-automatic. And I can hide it, and I can get much closer to you. And so I'm very close to you with a high capacity weapon that can fire rounds fairly quickly. With a long gun, I can't get close to you. By the time I go through the first room, word's out that I'm here, and you're gonna run away. Now, it's not to say handguns are bad and assault weapons are good. I never said that either. What I'm saying is there needs to be a holistic approach to firearm regulation and management. We should not say, it's very easy for a politician or a policymaker or anybody else with an agenda to say, get rid of the assault weapons. It takes 10 seconds to say it, and it is very sexy and appealing. It's just not factually correct.
So this panel, 3 of you are trauma surgeons. Yes, trauma surgeon?
Emergency medicine.
Emergency medicine. Lena, also?
I'm an emergency medicine physician also.
You were at Planned Parenthood. You're not at Planned Parenthood anymore. Those reasons have been adjudicated in the press. Planned Parenthood said that you were a bad manager. You said that they weren't supportive of your mission. Is this the kind of work that you want to be doing moving forward? Gun violence, public health?
Public health broadly, yes, because that's my background and training. As an emergency physician, everything that I do is grounded in my North Star, which is the patients and families that I serve, communities and people who are the most vulnerable. I see all of these issues as being interrelated. Actually, I used to show in my presentations of the health issues in Baltimore, I used to show maps that were color-coded. And then I actually stopped showing those maps because it didn't matter what I put in the legend. It was the same map. Because it's the same areas that have the lowest life expectancy, that have the highest gun violence, that have the highest infant mortality, that have the highest cardiovascular disease, that have the highest overdose rates, that have the lowest educational outcomes, that have the highest barriers to transportation. I mean, it's the map, basically, of social determinants of health. And I think for us to separate these issues and only talk about firearm safety separately, I think it's an important conversation. But we cannot separate these social determinants from each other. And we can't talk about public health as, well, this is the lane of reproductive health, or this is the lane of opioids and addiction, or this is the lane of gun violence, when all of these things are interrelated. I mean, I think what's missing in a lot of our conversation, including today, is the root causes that we actually opened the panel with discussing. I mean, I also think we should talk about how, for example, in Baltimore, we reduced the percentage of children with lead poisoning by 86% in 10 years. But still, the CDC estimates that around the country, 500,000 kids have lead poisoning by the time that they're 5. I mean, what about the impact of children who are lead poisoned, their proclivity to be victims of violence or perpetrators of violence later?
So to address those root causes, what is the most effective position for someone to be in? You've led a city health department, you've been an advocate, we have folks on the panel who are leading centers at hospitals. Where can a person make the most change on addressing these problems?
I strongly believe it's wherever you are. Don't wait for the perfect position or to be in the ideal role where you have the biggest platform. I think you do whatever you can from the position that you have. If you're a researcher, I really commend my fellow panelists who are researchers, who are physicians, who are practitioners, for doing everything that they can from the vantage point that they have. But there's a lot that you can do in policy as an advocate, working with a community organization, working as a volunteer. I also strongly believe that on the local level, programs that deliver glasses to children, provide food and family supports to enable kids and families to have a better future. That's all part of violence prevention. Anything that we can do to improve mental health and build resilience among our youth, that also is critical to addressing this issue too. So start wherever you can. Don't wait, because frankly, the time for change is now, and it has to begin with each of us.
Your mentor, Elijah Cummings, passed away recently, the congressman. You've talked about how much he meant to you. Your son is named after him. Are you interested in running for his seat?
Absolutely not. Absolutely not.
Let me call Maya.
Yeah, absolutely not.
As far as I know, she hasn't declared either, but it's due. Candidates have to declare the next 3 weeks. But you're not going to be one of them.
I am also expecting a baby in my second child in March. No, but I will. But I will also just say that, Congressman Cummings, as Dan mentioned, is my hero, my mentor. I named my son, Eli, after him. And if Congressman Cummings were here, he would talk about how the work that we have in front of us is so much bigger than us. Mm-hmm. That it's about our children. It's about the generations yet unborn. He calls our children living messengers to a future that we will never see. And he would also urge us to not just look for common ground, but to aim for higher ground.
I'd like to start bringing in the audience, and I think there will be a microphone that can circulate for folks who have questions. But before that, my last question as that microphone is circulating, and raise your hand, I guess, if you'd like to ask. It's for Mallory. A few weeks ago, my wife and I were watching TV on a Sunday night in our home, and we heard what we thought were gunshots. We ran up to our roof, we looked out, we saw the police swarming, and later I read that a young man had been shot and killed. He was 19 years old. And in the neighborhood looming over all of this, I could see the sign for Howard University Hospital. That's the neighborhood I live in, that's the neighborhood you work in. What does it mean to be practicing in a community where gun violence is not an aberration, it is a regular feature of what you do?
So it means, thank you for sharing that, because as you were hearing those shots, I was sleeping in my call room bed, and then the man came into the hospital, and I actually responded to that gentleman's trauma.
So you were actually
I was the trauma surgeon on call that night. And so we've talked about the 19-year-old and the subsequent community response, which I think is appropriate. I think the question, though, is profound, because it really means that, as a trauma center, as a level 1 trauma center, you got to really be prepared to do a couple of things. You got to be prepared to respond to the immediacy of what it means to take care of patients with penetrating trauma. But you also have to have an expanded perspective about the community that you serve, right? So that means that I can't just stay in my trauma center and do the trauma surgery once the gunshot has occurred. So what we say at Howard is this: we have a little bit of a different perspective of what a level 1 trauma center has to be in DC at this particular time. And that is, we have to engage with people in their lives long before the gun becomes a subject of issue. And so you'll see Howard University level 1 trauma center in the community. We've adopted a class at Thurgood Marshall Academy in Southeast. We are very much involved with anything that involves children and pushing them forward in the community and giving them an alternative to the natural pathways that exist. We are funding those things. We are present there. We have kids coming into our trauma center on a weekly basis, interacting with me personally, about conflict resolution, about what's going on in the community, just sitting down and having a conversation so that they can see that there is a different way to do what they might want to do. And I think that becomes mandatory behavior, right? And so as much time as I have to spare in my life, that has to be a part of what we do if we're going to be effective. Because as Lena said, you never can count the person who didn't get shot. But certainly we must be doing some of that when we're engaging in the community in that way. And that is work that is not seen, that is work that is not compensated for, that is work that is mandatory.
Do we have any questions from the audience? Gentleman with the microphone.
Hi. Thank you to all the panelists. My name is Chris Corey, one of the American Medical Association. Thank you for your dedication to this really important issue and the time you've devoted to it. My question is to ask the panelists to elaborate a little bit further on kind of the order of magnitude and the nature of the research funding you think is required. You mentioned the nights and weekends you're spending. You spend there's a lot of ways physicians spend their times on nights and weekends. And what dollars do you really need to get stuff done, and what's the nature of how you devote that money?
So if I may, there was a paper published in JAMA in 2017, and then I recently published a paper in Health Affairs that came out just a few weeks ago, talking about the huge differential between what one would predict should be spent on gun violence research versus what's actually being spent. When you look at the number of injuries overall, or the number of injuries for children and adolescents, right, gun violence is the second leading cause of death for kids in our country. The amount of money that's being spent on the necessary research is less than 2% of what would be predicted. We need billions of dollars to be spent on this. The $50 million that was in that House package that is not going to make it through the Senate is better than what's currently being spent, but it is absolutely not sufficient. That said, right now, small amounts of money, such as that being provided through partnerships, through AFFIRM Research, Kaiser, Arnold, et cetera, are transforming the field because there has been a drought of money for the past 23 years. So since the Dickey Amendment was passed in 1996, there have been $0 in appropriations to the CDC.
And
right?
this is the amendment that essentially made it moot for funding for the CDC.
Correct.
The congressman later said he felt like it was overinterpreted what he meant to do.
Exactly,
Yeah.
that's exactly. And so since that time, there's been virtually no research. So right now, even little bits of research will fund the stuff that I do, the stuff that Babak does, right? Like this is the stuff that no one is doing. And so right now we can start to move the needle with on some low-hanging fruit. But long term, I mean, again, look at how much we're spending on opioids, which kill a similar number of people per year.
Babak, is it getting easier to find funding in this moment that we're in?
Definitely not, no. I would suggest the ability to obtain funding for firearm-related research is, at my level, at the local level, boots on the ground guy, unchanged.
Yeah.
Flip that question around for a second. The idea that there should be more research comes out of a moment when folks were scared to do that research.
Right.
Has there been any retribution in your professional careers or the careers of people you work with for trying to study gun violence?
In my world, no. In fact, in my world, it's helped. So, I've made a little bit of a reputation for myself as someone who is into this type of research. I don't think that, certainly there's been no retribution whatsoever. If anything, it's allowed me to assume an area in which I think I can contribute to the public good, and in which I am acknowledged by my peers as a guy who's trying to contribute to the public good.
And I'll actually say that that's shifted tremendously. So when I started doing this work, I was actually told very explicitly by my mentors, by my supervisors, that this was not something that I could talk about, that I was going to endanger my career and potentially bring my kind of hospital system into the public eye in a way that was not desired.
How long ago was that?
That was 8 years ago.
8 years ago.
So that has shifted, yeah.
Next question.
I will say though, it does get a
Or
little
next
bit.
point.
It does get a little bit complicated when you broaden this conversation and you get into excessive use of force. Six leading cause of death for African Americans 25 to 29 in this country is police use of excess force. Rutgers data that just came out. Kudos to California for legislatively coming forth with the research money. Kudos to New Jersey for legislatively coming forward with the research money and not waiting on the federal money.
So we're still in a moment where we don't know what we don't know
Yes.
because there hasn't been enough research and there hasn't been enough
Yes.
embracing of this data. There's a person with a microphone in the back.
Hi. So as a parent of underage kids, I know exactly that I could lose everything if they were to raid my liquor cabinet and go out and get hurt, however it is that they could get hurt. When I look at coverage of gun violence, whether it's two kids who pulled a gun out of whatever it is, I never see the follow-up coverage of what's happening to parents who don't lock up their guns. Like, at what level is that conversation happening? Is it a language conversation that's happening among gun owners, or is there any policy discussion? Because I'm not seeing it.
It's a great question.
Do you know?
So we do a fair, so there are safe storage laws in a number of states across the country. They vary tremendously. They are very rarely enforced. And it gets back to that question of we can pass more laws, but we need to also manage the ones that we currently have. But you're right, so most school mass shooters actually use a parent's gun. Most kids who commit suicide use a parent's gun. So there absolutely there is a growing discussion about that that's happening.
Yeah, I spoke to a fairly high-ranking police officer, not in Washington, D.C., in a state that has reasonably liberal gun laws. And I asked that exact question of if a young individual grabs his father's weapon and then goes out and commits a mass event, could you hold the father accountable? And the firm answer was absolutely not. So it varies state by state. Now, mind you, I specifically chose a gun liberal, if you will, state because I wanted to know where do things stand starting at that level.
I think your question brings up a really important point that the policy alone is not enough unless you also have implementation. And unless you have widespread implementation, including education and service delivery too. I mean, I think one of the things that got a lot of physicians animated around this issue is gag orders that were being placed in Florida and other places that were trying to forbid physicians from discussing with our patients about whether they have firearms in the house. I mean, it's crazy to forbid us from asking about something that could harm our patients and their children and everything else, right? And so I think that got a lot of people animated. But I think that's another important part of the education, that it's a core public health principle is meeting people where they are. And every interaction should be a point of intervention. And that might include the doctor-patient relationship, but even beyond that, potentially there could be other avenues for education, not just the laws about safe storage, but also education in community settings by trusted messengers around this.
And I'm actually going to go off of that trusted messenger comment, that I think that one of the reasons that the Florida gag law was passed was because a pediatrician asked a parent if they had a gun, the parent refused to answer, and the pediatrician then fired the parent from the practice. I would argue that that is not, kind of as a physician, that is not respecting my doctor-patient relationship. And I think one of the things that we can do that could cause the most harm is to have these conversations from a place of judgment. And it's where, again, kind of AFFIRM research that we include gun owners as leaders, right? And that we're trying to focus on this as being a harm reduction conversation rather than as a judgment about someone's intelligence, or like imagine Mallory if I was like, how dare you, that just doesn't go. It doesn't go for discussions about opioids, right, about safe sex, anything else. And I think the one danger with the safe storage laws is that I've heard anecdotally some stories of some kids who have tried to commit suicide with a parent's gun, and then you have a family that's in the midst of healing, right, at the same time that a parent is potentially being prosecuted, and I don't know that actually does a lot of good for the community either. So there's a lot of nuance in it that I think, again, research can help make a difference in, to give us good tactics to make a difference.
Next question.
Mina Vajlingam, quick question about really going proximal and going upstream interventions. I want to tie the upstream intervention with the root cause analysis across various conditions like homicide, suicide, opioids, poverty, so the whole social determinants of health. In terms of looking at the proximal point of intervention or an innovation or opportunity for innovation, how would you link all these conditions and try to sort of come up with a root cause analysis? Has it been done, and are there any hypotheses? Is there data?
I mean, I think that there are a lot of data and hypotheses around these, right? Because we do see the correlations all throughout. We see the correlations when it comes to, as you were saying, all these diseases of despair. Mm-hmm. Suicide, homicide, drug use, right? All of these are the diseases of despair. And what's underlying that, I heard someone say around opioids, but I think it equally applies for something like suicide, homicide, and gun deaths too, which is if tomorrow looks no better than today, what do you have to lose?
But I think that's the question, right? Is it jobs? Is it connectedness?
So,
is it...
But I don't think there's any single, I think that it's the same thing as kind of saying it's about laws. Like, there is no single, so one of the things I hate about this topic is you can't not use gun metaphors, so I will say there's no single magic bullet, right? There's
a magic wand.
There's a magic wand, there you go.
Very good.
Right, there's not going to be any single solution any more than there is for opioids or for HIV.
But has anybody looked at effect sizes of,
So remember, we've had virtually no funding. I am on 3 of the 15 federally funded grants around gun violence right now. So, I mean, just the funding.
And to put that in
is-
context, I mean, there are thousands of grants on something like cancer.
Right.
Yeah.
Or for opioids, they're around, 700, right? Like, it's just the scale of research that has been done is like this,
I would encourage you to go through the opioid door, but address the underlying root cause analysis, because there's a lot of funding in opioids, but not much. But you could make a case for diseases of despair.
Absolutely.
Well, I have a quick follow-up for Lena. So I grew up in Baltimore, and I don't know if that's an awe of.
No, one of my best friends grew up in Baltimore, and
Baltimore's a small town. Maybe we know each other.
Probably,
But Baltimore, and I think I've written about this before, we may have even talked about this, it really does feel like two cities. There's the city of Johns Hopkins and beautiful parks, and then there's the city where diseases of despair are all too common. And when there is a crisis, how easy has it been to convince the people in the cheery part of Baltimore that they may need to do more, they may need to sacrifice funding, whatever it might be, to attack those root causes of the problems that are plaguing the other part of Baltimore?
I actually think that people who live in Baltimore, who could live elsewhere, choose to live in Baltimore because they're really dedicated to the city. I mean, I would count myself and so many colleagues that I've had the privilege of working with over the years as part of that. So I actually don't think that it's lack of political will. I think it's just as with any other issue, I think people want to address the low-hanging fruit that's really quick. And I actually agree that we should do that too. But what can we be doing that will make a difference 5 years, 10 years down the line too?
Can I make a point? A point that the last lady in the audience raised. So I approached a psychologist several years ago, and I said, we should look at shootings. Again, my particular area is public mass shootings, but shootings, and discuss and maybe research this concept of mental health, because that seems to be another talking point. If we could just, frankly, if we just get rid of the crazies, all the problem would go away. So is that true? And he and I had a very insightful conversation for me, and I walked away having learned a few things. And the short answer is, of course, no. There's no funding for research. And in fact, there's no basis to really allege that the majority of these events, or even the plurality of these events, are due to people with mental health disorders. And I'll give you a quick case in point, and then I'll move on. Because I had a very hard time understanding what he was saying. And I kept saying, but surely these people are, at some level, mentally deranged. Why else would you shoot a bunch of kids in Sandy Hook? And there's got to be a reason behind this. And he said to me, look, Bob, the person with whom I was speaking is he's a full professor, and he's an African-American psychiatrist. And he said, look, Bob, if in 1800 a white guy lynched a black guy, would you call that guy crazy? Mm-hmm. And I was like, well, I mean, it's a very uncomfortable question to answer, but I guess in the context you posed it, no. And he goes, that's exactly right. That was culturally acceptable. Today, we think that man is crazy. So it is far more complicated than to say, let's look at this from mental health. Mm-hmm. It takes into, you have to factor in socioeconomic factors about which we've been speaking. You have to factor in cultural factors. Remember, the Pulse nightclub shooting was an exact attack against the homosexual population. You have to factor in a lot of outside influences that come into that individual's head when he or she finally decides, I'm going to make a move today. So, and to do that requires tremendous funding and multidisciplinary support. You need the psychiatrists on board. And when I ask them, okay, well, you win. I understand what you're finally saying. What's the solution? He goes, oh, the solution is very simple. Decades upon decades of psychotherapy for every patient. So, right.
Yeah.
So, these one taglines you see on the news, ban assault weapons, mental health, none of these are just taglines, and that's all they are.
Which is why we're having this panel. Next question, the woman in yellow.
I was going to say, Kenyatta Hazelwood, I'm a trauma program manager and a nurse, so I also get to see some of these these patients come straight to our trauma center. But to piggyback off of both the panelists, Dr. Ranney, and a question here, when we have a hospital-based violence intervention program, and those credible messengers that you spoke of, and violence interrupters, when they come back and they tell us why these patients are committing, why they're perpetrators or victims of violence, it often centers around all of the wraparound services that we need, housing issues, jobs issues. It's real. It's not one point that can help with getting them away from gun violence. And I wanted to ask about your perspective in terms of this being a racial disparity, and where do you stand on this being because we know that suicides and mass shootings and urban violence, but a lot of children are dying by urban gun violence. The mass shootings is only a small percentage of death for these victims.
Great question.
Mallory, Babak, you both run trauma centers at hospitals. Any thoughts?
So she's right. I mean, you look at the pie, 2/3 of that is going to be suicide. Megan has covered that well. And you got less than 1% that will be mass shootings, and then you still got 13% that are going to be in some way gang related. And how big is that? It's about 40,000 deaths and about 80,000 morbidities. In terms of the disparities, I do think that it's clear the statistics show you that in general, if you look like me, you're going to die from homicide. And if you look like the moderator, you're going to die from suicide, in general.
Oh, goodness.
That's very tricky, though. That's very tricky. Because once you dig down into the data on suicide, right, you find that African-American children are clipping themselves off at a rate of about 8 times their peer group rates. You find that adolescent African-American women's suicide rates at 160% up. You find that African-American male suicide rates are 60% up. So suicide, right, typically known as a Caucasian rationale for, not rationale, but reason for gun death, is emerging dramatically in minority groups. And the why behind that gets back to all the things we're talking about in terms of the research, understanding those consequences. So yes, there are disparities that we see on the face, but I would caution everybody to just taking that as a take-home message, and because as you drill down into this data, it gets very provocative.
I do think that your calling out the issue is so important. I do a lot of work with opioids also, and I think it needs to be said that around opioids, Black and brown people have been dying of the heroin epidemic for decades. And it wasn't until white people in suburban, rural areas that started dying that we finally said this was an epidemic. And I think something similar could be said about gun violence too, that we've had urban gun violence killing minority populations for a long time. And now there are mass shootings that affect other communities that there is national attention in a different way than there's been before. Now, I think that national attention is needed, and actually we need a lot more and a lot more funding. But I think calling out the structural racism behind our historical policies and how we got to where we are is really critical.
Next question from the audience. Gentleman with his hand up, getting the microphone.
Hi, Josh Wright from Ideas 42. I have 2 questions. One is maybe tougher, which would be, do you really think that this issue can be solved if we don't address the political divide? So that's the harder question. The easier question would be, what's the most interesting or compelling new innovation that you've seen around solving some of these problems? Like, you could imagine Walmart starts defaulting or putting a choice in the baby registry for people to buy a gun safe as opposed to a stroller. So I'm curious about the second one also, about sort of innovative ideas or novel things you've seen.
Both great questions. Let's start with the first one. Can we address this without addressing the political divide?
Yes.
Yes, but not completely.
Go deeper.
Okay. Our structure of government is kind of intuitive with not making a lot of change, and this is a big change. We have to face it, that where we need to go is a big change. And so until Ohio, the middle part of Pennsylvania between Philadelphia and Pittsburgh, Michigan and Wisconsin become wholly vested in this issue, that's a presidential schema I'm putting out there. It's going to be a difficult thing to solve politically. Not impossible. We saw in dating with that mass shooting that the people welled up and they said, do something, do something. They chanted. And the governor there, who is a Republican, I have a home in Toledo, Ohio, full disclosure, did something the next day. We saw that Rick down in, the governor in Florida did something after the Parkland incident. More importantly, in Florida, you saw a viable African-American candidate for governor in that state after the Parkland shooting. And then you saw Stacey in Georgia. So something will be done politically, but it's a difficult fix.
But I think that so much of this can be done. I mean, so certainly, again, policy is important. We're here in D.C. I don't live in D.C., so full disclosure there, right?
Lucky you.
But so policy is important, but so much can be done right now with the policies that are already in place. Are other policies and different policies potentially needed? Sure, but that doesn't mean that we are hopeless or unable to act at this moment. There's so much that can be done outside of policy change, whether it is improved enforcement, education, whether it is these community-based interventions, whether it is business collaboration with business, as you have mentioned. There's a lot of stuff, just as we're not fixing the opioid, fentanyl was already illegal, heroin was already illegal. We're not fixing the opioid epidemic by passing more laws, right? We're fixing it by addressing other interventions, and the same sort of thing is possible here.
But some of it is, though, Congress on both sides has come together to fund
Totally
massively
true.
opioid response.
Well, that's true, yes.
I
Yes.
think it'll be a mix of everything, but it's going to be slow. So I do think there has to be some movement on the political side, but I'm a little bit more on Megan's side than on Mallory's side. I think they're both right, but we don't have to wait for the. How's that for a political answer?
Yeah. You're a DC liver.
Yeah, I live here.
And I thought
think
you were
there
right
has
in the middle.
I know, right? I think that there has to be some movement on the policy side, but I think this will be driven far more, to be honest with you, on the commercial side. You already see that Walmart's making some moves. If you were to go home today and call up your insurance provider or call up your employer, however which way you get insurance, and you say to them, hey man, I smoke, I don't exercise, and I love burgers, your insurance rate will go up instantly. And there will be some movement there to say, sooner or later, if you have a gun in your house and a child, odds are that child will hurt himself with that gun, and the insurance provider is not going to pay out for that.
And in the time remaining, let's take the second part of that question. The most innovative intervention that you've seen, anyone?
Absolutely. I think, you got to look in terms of a result at the consequences of what happens when you execute red flag laws. I mean, I think that, for me, I was surprised by the data that says that it can work and be effective in the jurisdictions when implemented. And I think we have to nuance that a little bit for all populations, but I'm happy with what that data says. For those who may not be aware, red flag laws are saying that when we petition our local governments, that we can hold in custody weapons when we feel that a loved one or someone we know is mentally or in any other way unstable at the time.
So I'll take us to the end, I think, by saying I heard as moderator that this is a moment in the physician community of optimism. How much optimism, a little bit to be determined, but the energy, the enthusiasm, the work that is being done. By the same token, some of the political catchphrases on assault rifle bans or mental health and mindfulness are misleading and wrong. There are advances being made in research, but there's still just a pittance of funding. And there's confidence from this panel that big federal initiatives aren't as important as, say, violence interrupters, addressing upstream interventions in a place like Baltimore. And if we come back in some form at a future Milken conference, there will be tremendous progress made because of the optimism and the work of physicians. So, Doctor, thank you so much for your time.
Thank you.
And all of them will be after the panel available, I think.
Thank you very much.
Thank you.